Dr. Melissa Pierce from Truro University, California. I'm Vice Chair of the Osteopathic Manipulative Medicine Department. I'm a family medicine physician and a specialist in osteopathic manipulation. Did family medicine at Modesto. It was Stanislaus Family Medicine and now Valley Medicine. And then I did a year of additional training specific to osteopathic manipulation at the, with Dr. Hugh Edlinger in the Bronx.
My name is Lori. I'm a graduate from UC Davis, and I have my bachelor's in exercise biology. And right now I'm working in Pleasanton in DNA manufacturing and taking classes at Chabot to get ready to apply to school this year.
Great.
I know, yeah. Yeah, for research companies, they use pre-made DNA oligos, and so we make that for them. Great.
Make a circle.
Okay. So I'm Pam. I graduated from UC Berkeley, majored in chemistry, did my own thing for a while, and then decided to go into medicine. I did the postbaccalaureate program here at East Bay. So I'm currently in the application process, and I applied to Truro.
Okay, great.
I'm Brett Judson. I'm starting my second semester at Chabot Community College. I'm going to major in kinesiology and physical therapy, and so I'm here to learn about the next portion about physical therapy, but we learn about medicine as well.
Great.
My name is Peter Carr, and I have my bachelor's. I actually did that in North Carolina, and I'm doing the post-bac program here. And I'm a good pediatrician.
Great.
I'm Rita. I'm from Sacramento. I go to Sacramento State. I'm a bio major, and it's my third year there, and I want to be a pediatrician also.
I'm Emin, and I go to a community college in Sacramento, and I'm transferring to a CSU in the fall, and I'm majoring in health science, and I want to be a dermatologist.
Okay, I was going to say, if we get another pediatrician, that would really be something.
Yeah.
Great. Well, and you want to...
Oh, I'm Natalie. I'm a senior here. My major is biology, and taking my MCAT soon.
I'm just volunteering. Actually. Yeah. I go to another school in San Francisco.
Yeah,
But-
great. Didn't want to leave anybody out. Great, so thanks for the introductions. And then what I'll do is make an introduction to osteopathic medicine with a little presentation. And then, though I didn't have a chance to get a table here, I'll do a demonstration of osteopathic manipulation. Because sometimes you're not always able to lay a patient down in order to treat them. Treat in seated positions as well. So I'll just do that. So, let's see. I assumed that this was a slide advancer.
Oh, yeah.
So I will come sit over here. Let's see. Let me scoot so I'm off center from people here. And I'll do this. Great. There we go. So, some people know what is a DO because we are applying to Truro. I expect at least a little bit of background knowledge. So how many of you have seen a DO, know somebody who is one, or have knowledge of osteopathic manipulation? My Truro applicant, yes, great. So that just gives me an idea of sort of what level of detail to speak to. So I'll tell you a little bit about doctors of osteopathic medicine, that's what a DO is, in juxtaposition to an MD or allopathic physician. DOs are licensed to practice in all states in the United States. I won't speak much to the differences between osteopathic medical training in the United States compared to that nationally, other than to say that the international graduates are focused on manual medicine and don't have full medical training. In California, we have two schools, Truro University on Mare Island in Vallejo, and Western, which is down south in Pomona. And nationwide, we have about 73,000 DOs practicing. And there are, oh, I didn't update my slide because the osteopathic medical profession is growing rapidly, and we now have 37 campuses. Some are branch campuses, there are lots of subdivisions and things like that, but basically 37 osteopathic medical schools. And it's not all about manipulation. When you have your medical license, your osteopathic medical license, you're basically geared toward what you practice by your residency. So you're licensed to perform surgery if you're a surgeon, or procedures if that's in your training in family medicine or OBGYN, for example, and to prescribe medication. Your DEA license is what tells you what class of medication you can prescribe. And board certification is available in all specialties. The tracks can be through an ACGME or MD residency program, or an AOA DO specific residency program, but all residency programs are represented. And then specific to osteopathic medicine is my second board certification, which is neuromuscular medicine, osteopathic manipulative medicine board certification. So easier to say NMM, OMM, right? So where does osteopathic medicine come from, and how is it a little bit different or the same with allopathic medicine? So Andrew Taylor Still was an apprentice trained MD in the mid-1800s. He apprenticed with his father. He was a Civil War surgeon, and as he, let's see, I think I jumped ahead. No. As he was practicing, he became very disillusioned with the medicine of the time. Of course, we didn't have medications, antibiotics, there was bloodletting and toxic chemicals used as medicine, so he was right to become a little discouraged. But what he did with it was to start to look at the function and structure and the anatomy, and to begin to develop the ability to diagnose and treat patients with his hands. Currently in the osteopathic medicine, I did update this slide, 29 osteopathic medical schools have 37 teaching locations, and the similarities with MD practice are that we have essentially the same curriculum within the first 2 years of medical school, along with an extra 200 to 500 hours of training specific to manipulation. So we have an anatomy and physiology and pathology and clinical medicine and you name neurology, neurosciences and microbiology and all those sub-disciplines. Specifically in Turo's curriculum, they are all integrated into a longitudinal curriculum rather than being discrete pieces. So osteo what? A common question is you say, I'm an osteopathic physician, and they're like, oh, is that the bones? And I actually had a curious factoid that I haven't had a chance to research. I just learned this a couple days ago. So people think osteo must be like osteoporosis or something to do with the bones. But there was a comment made in an osteopathic course I went to that said, actually because Andrew Taylor Still in his study of anatomy was involved with the Indian tribes and was using skeletons in order to investigate anatomy, that there's a possibility that the osteo component of osteopathy may have some Indian roots. So I wanted to do a little language search and look into that a little further. But it's not all about, whether it's osteo for bones or osteo from an Indian language root, it's not all about the bones, because osteopathic manipulation addresses the whole, osteopathic philosophy addresses the whole person, and osteopathic manipulation also encompasses treatment of the whole person. So you can use OMM to address any part of the system, the nervous system, lymphatics, musculoskeletal, of course, that's what's thought of first. And the fascia and interconnectedness of the whole body really helps with the ability to treat. And what is that osteopathic philosophy? The philosophy is that the person is more than just their body. They are body, mind, and spirit. They are a unity of body, mind, and spirit. And that the body itself is capable of self-healing and self-regulation and health maintenance. Structure and function are reciprocally interrelated, so if you have loss of structure, you are likely to have loss of function. If you can improve either structure or function, it will reciprocally improve each other. And that rational treatment is based on these underlying principles. So although we get lots of referrals for back pain, it's not all about back pain and musculoskeletal problems. And the Unity principle also helps OMT address issues beyond the body system. So as you're working with someone physically, you're also working with them emotionally and spiritually, even if you're not specifically addressing that area or arena. That's all going to be involved. So you may have improvement in a somatic structure, improve function, and improve another arena as well. And there's lots of ways to approach manipulation. I broke these out into two kind of categories, direct and indirect. Now this is part of the OMM curriculum that spans 2 years of didactic and hands-on laboratory experience, as well as the early clinical experiences, and then branches out into the 3rd and 4th year, and hopefully into people's entire practice. Unfortunately, the application of osteopathic manipulation can be time intensive, and so trying to get a practice setting in which you can fully apply osteopathic manipulation can be difficult. But our goal is to have at least the underlying philosophy and the palpation skills and the things that are learned in the first 2 years and in rotation training will carry through people's career. And I say that to say that I now have a slide up with like a couple years worth of curriculum, and won't try to run through it all with you in this moment. But basically, there are direct and indirect approaches to treating, and so a direct technique will be something where you move something to where it won't move any further, and then by some approach, whether it's articulation, like coming up against a barrier and moving it, or by a thrust, like a high velocity, low amplitude that might be similar to a chiropractic adjustment. Those would be direct techniques. And then indirect techniques would be if you take it away from that barrier to a point of balance tension where the tissues or the system can release. So examples of this are muscle energy, isometric muscle contraction that produces a neurologic change in the neuromuscular relationship. You notice that some of these are on both sides of the slide, like balanced ligamentous tension, because you can apply the techniques of engaging the ligaments and producing a release to either the direct barrier or away from the direct barrier. And I think that was pretty much the summary that I wanted to do, so that we have a little chance for a demonstration as well. I was going to say that osteopathic manipulation applies to all people, so you can have families and kids and pregnant women and people who have had surgery or are going to have surgery, people who have had an injury, healthy people, disabled people, and people who are on a path to dying. I have some people doing hospice work. And I can go to a demonstration. So, but before I do, since we have more time than sometimes with a larger group, do people have questions for me? Yeah.
Well, I guess since you mentioned your chiropractics, from what I observed, it seems to be very similar, if not almost the same thing as chiropractics. I guess what would be like a differentiating factor between?
Okay, so I can speak kind of on 3 levels to that question.
Mm-hmm.
So one is the breadth of training. So chiropractic schools have expanded over time in some settings. Some chiropractic schools continue to be 2 years, some are 3, and I think there are a couple that are now 4. But they do not, the main focus is on the adjustment, on the chiropractic adjustment. Spinal, and understanding the anatomy and physiology related to that, compared to the full breadth of medical school. There was a petition to license chiropractors as primary care physicians in the state of Ohio, I believe, and it was declined, turned down, whatever, because of that, not having that full scope of training in the schooling, and also not having the requirement to go on to internship and residency. So there are people physician assistants and nurse practitioners have a scope of practice acting as a primary care provider who don't have an internship and residency, but they do have 3 years of more broad-based kind of curriculum. So that's one aspect. In terms of the actual comparison of manipulative methods, the treatments themselves, there was an observation that David Palmer, who started the first chiropractic school, visited with Dr. Still for a week in his clinic, and then went and started the chiropractic school shortly thereafter. And then those disciplines grew further. Dr. Still had been practicing for 18 years before he started his school, but then their schools grew concurrently. The early forms of chiropractic manipulation were strictly the direct take the spine and its articulations and its ligamentous attachments and its nerve roots, and the focus was to bring a misaligned spine back into alignment. So a chiropractor would call, get my hands to be fine here, call it a subluxation, right? So a less than disarticulated vertebra in which, but that is out of alignment. And then the goal would be to come up against this part and thrust it back into position. And so the assessment through the spine would be for misalignment and for putting it back. And many chiropractors would use kind of a multiple segment approach and just articulate any level that was out of alignment. And with the idea that that then influences the rest of the body with the nerve root innervation, and that is part of our understanding and philosophy as well. We spent a lot of time studying viscerosomatic reflexes and how the brain's talking to the body and the body's talking back and how the dysfunction happens. So.
Because like the philosophy is pretty much the same. The body's, a miracle healer. Pretty much, fixing the body will fix, other problems.
I'm not sure that chiropractic has that as a philosophy. I think my understanding, I worked for a chiropractor for a while, and I know some people, and I had a faculty member when I was at Toro who's still there actually, who is a chiropractor, and so I have some personal knowledge as well as things I've read, but I expect chiropractic philosophy to speak more to the interrelationship between the spine and its function and the nervous system. I haven't heard it articulated to say the body has self-healing properties. But now you have me curious, so I'll have to go look that up in addition to the Indian. But I had so many lectures this week that I was like, I couldn't do any extracurricular, I'd like to know that too, let me look that up. It's very common as a practice model for a chiropractor to set up a treatment plan that spans a certain amount of time and has a certain number of visits. Like you'll hear people say, I went to my chiropractor 3 times a week for X amount of time and then 2 times and then 1. And osteopathic physicians just generally, my colleagues and people across the country tend to treat, have someone back in a week, see how they responded to the treatment, and then make a treatment plan that follows their clinical course. And the way I look at it is, if someone has a baseline of function here, and you do your manipulation and things improve and they have changes and they get to here, but it's not going to hold because it's not a one-time everything's finished thing, and they start to come back down toward their baseline. If you can catch them right about here in time, that's the best effect, because you haven't used up the amount of the effect of the treatment, but neither are you back where you started. And I can speak to that from my clinical practice, that I have somebody who's been in pain for 20 years, gets this horrible muscle spasming across one side of his body, been worked up medically for all kinds of things, and there's nothing wrong with him. There's no discs out of place, there's no underlying endocrine problem, there's no underlying metabolic, infectious nothing else that can be discovered to be going on. But he has the spasm and has tried all kinds of chiropractic and massage and physical therapy and magnets, and he's worked with lots of things to try to get better. And I was seeing him like every 2 weeks for a little while, and he was making progress in sleeping better, still in pain, but not having grabbing horrible spasms. And there was this period of time in which I just could not get him into my clinic for about 5 weeks, and he was almost back to where he started. But the good thing was that having had manipulation a few times, that next manipulation really made a difference, got him farther along than like the difference between the first and the second. So different practice model was the third thing I'd say.
So in the fields like pediatrics and cardiology or dermatology, what would be the difference between how an MD would approach a patient versus how a DO would approach a patient?
Okay.
The treatment.
So I can speak to that in 2 ways. That dermatology maybe a little less, although there's manipulation you can do for like scar tissue that can make a difference with that. But for pediatrics, whether or not you actually did manipulation, which kids can benefit greatly from manipulation, but even if you had a kind of pediatric practice in which you didn't have the time, didn't have the infrastructure, you were working at, I won't name names, a big healthcare system that limits the scope of practice for physicians. For example, a family medicine physician will actually see outpatient adult medicine rather than adults and kids and pregnant, whether it's the actual care to delivery or just prenatal. That in that setting where your scope is more limited, you can still apply osteopathic philosophy and assessment and your palpatory evaluation, even if you aren't doing manipulation. So, for example, if a pediatric patient comes to you with asthma, you're going to, of course, use the interventions that are appropriate. Start with short-acting beta agonist, move to long-acting beta agonist, add a inhaled steroid, use a systemic steroid as needed. But you're also going to recognize that their function, their ability to breathe is affected by the structure. So they're having nighttime coughing and they're getting ribs out of place. And so hopefully you'll have the time to manipulate them so that you can affect that part as well. And there's studies also in peds, just since that's an area of interest for people. There's studies in otitis media that if osteopathic manipulation is added to routine care, whether the patient is someone who warrants an antibiotic or not, that the incidence and frequency and duration of otitis media infections are decreased in the patients who are routinely given osteopathic manipulation along with their other care. But, yeah. Okay.
Go ahead.
Have there been any challenges, I guess, in your work or even with your own colleagues that were patients were either surprised by OMM or even maybe refused and weren't feel comfortable with the OMM kind of therapy?
So was the question for patients or colleagues or both?
For patients, I guess, and conferring with you yourself or with your colleagues, have you guys come across that in your work?
Sure. I mean, any procedure relies on informed consent. So the patient needs to know what you're going to do and how it's going to go and expected outcomes and what's involved. So anytime I see somebody and I plan some manipulation, I give them an introductory statement about what it is, what it'll feel like, I'm going to have my hands on, and this is the diagnosis, and then the treatment itself will feel much like this, or if I'm going to move anything quickly, I'll let you know, because I occasionally do something similar to a chiropractic adjustment. So DOs call it high velocity, low amplitude, so HVLA is much easier. And so I let them know what to expect, and if someone says, oh, I don't know what that is, then I either won't do it or explore it with them a little bit further.
Is it that typically they are open to it? And
yeah, people are like, yeah. For example, I was in my family medicine practice on Friday, Oh, it was only yesterday. Oh my goodness. Yesterday, and I had someone come in mostly to assess his high blood pressure, and he was having headaches. And so, really having evaluated his blood pressure and worked on his med combination, and thought that the numbers he was bringing me home really indicated a machine miscalibration problem, and directing him to the pharmacy to either just get another one or get it calibrated or bring it in and have us assess it the next time. And having assessed that he wasn't like having neurologic changes involved with headaches, so like he was having a stroke, or, I got to the point where I checked his head and he had muscular spasm going up the right side of his neck, pulling on his occipital bone and his occipital mastoid suture, and his occipital mastoid suture itself was jammed. And I put my finger on the jammed spot, and he goes, "That's right where my headache is." And so I described manipulation to him and asked if he wanted to have it done. He was like, "Absolutely, if there's something that can help me." I said, "The only risk is you could have a little bit of a flare of headache, but it may help with the headaches." He's like, "That's fine, I'll go into some informed consent," told him risks and benefits. And then I did manipulation to the, just seated, just like a couple minutes in this busy urgent care kind of family medicine setting. Did a little bit of manipulation for the muscles in the neck, lifted and separated the sutures with like a cranial osteopathy approach, got a release at the suture. He didn't have headache, and he may come to the osteopathic manipulative part of our practice, or I may never see him again and I won't know if it helped, but in any case I took those couple of minutes to see if I could help him.
What was the technique to relax the muscle?
So I used facilitated positional release, which is directed to the myofascial structures and also at an articulatory level. And it involves putting the spine into a neutral, and the muscle group into a neutral position, adding an activating force of compression, and then moving the region into its direction of ease in an indirect manner until it releases.
Whoa.
That was an hour-long lecture, not including the history that Dr. Shiowitz was the one who developed this approach to osteopathic manipulation in 30 seconds or less. We have until 10:50, is that correct?
Yes,
Okay.
yes.
Great.
And I just had a, just an overview comment that I'm sure in this day and age where everybody's really focused on organic and holistic approaches, even with the things that they eat, I think it's very important. And I think a lot of the general public is making a shift towards natural medicine and alternative, when I say alternative in terms of just treating it with Tylenol, treating it with aspirin, or treating it with medication, or so I'll just have surgery for that. I think osteopathy is, it's a great practice for medicine. And with that, my question was that how long, I know the DO program is 4 years at Toro, so how long is the didactic portion, and then do you make the shift over to clinical, or do you kind of implement that into the freshman and sophomore years, first and second?
It's something I wish I'd spoken to at the Dean's panel, but it is primarily didactic in the first 2 years and primarily clinical in the second. But we do look for opportunities both within the curriculum and in our faculty-supported volunteer opportunities to have people have clinical experience early. Because it is very frustrating to be sitting, reading, looking, learning, even with the case-based interactive components and the labs and the anatomy lab and all of that part of the curriculum. If you don't have the patient as your springboard and your level of understanding, it gets frustrating. That's true like in the overall medical school curriculum, the overall osteopathic medical school curriculum, and also kind of specifically to the manipulative part of the curriculum, because if you're working with each other in a lab and you're trying to diagnose problems and everybody's pretty much healthy and the dysfunctions that they have are based on bad posture and overwork, you don't have as much defined as if you're out in clinics and you've got someone come in with COPD and their chest doesn't move, or congestive heart failure and they're fluid overloaded, or pick your disease process that really then gives you not only your medical physical exam findings that have meaning rather than being like, well, I'm looking for jugular distension in the proper position and I'm not seeing any. Well, because your patient's not fluid overloaded. Good. So the early clinical experiences are built into the curriculum with a number of different sites. There's nursing home and there's like a success center where people come for support in finding new employment, and we'll have a screening history and physical in that setting as well. And correlating with a new program. I'm not as familiar with the program that's out in Richmond because they're just implementing like a new site. And then, so then the first 2 years there's continuity patients to be seen there. And then there are a number of different settings for students to come and volunteer. So the student run-free clinic, of which I'm the medical director, is in a professional environment in which the pharmacy students, PA, and COMS, the College of Osteopathic Medical students, all come and do screening history and physicals. The COMS students do manipulation. We have medication therapy management program that the pharm students are running. We have a case management program that the MPH students are running. And they have all of that clinical activities on Thursday nights, and generally book out our OMM about 6 weeks. So it keeps everybody busy. So that's like one volunteer opportunity. And then we collaborate with UC Berkeley. They have the suitcase clinics in Berkeley. One's in a women's shelter, and another one is in a church-run facility where they have medical and massage and nutritional counseling. They've got like 14 things going on at the same time, and one of those is OMM specific. So the osteopathic medical students come specifically to do manipulation in that setting. And then on campus we treat the students and faculty and staff at a lunchtime clinic.
So you were saying that a residency program available to DOs is like surgical. So how would that work in terms of like the philosophy of osteopathic medicine and surgery? Because they're kind of conflicting, I feel like, I don't know.
It depends on if your surgeon's dedicated to making money with as many procedures as possible and you avoid a few procedures. No. It actually goes together really well. One of the lectures that was keeping me busy this week was the bookend to a surgical patient lecture and lab. So a week or so ago I gave a lecture on kind of the inpatient major surgery immediately post-op kind of patient setting. We did labs on that during the week, in which the simulation that we did was that the patient really can't sit up and you can't do a lot of the anterior assessments that you might do if they've got like a big midline abdominal incision. And then the lecture for Friday was preoperative care, postoperative care, and sort of specialty specific like OBGYN and orthopedics and things like that. So, I mean, if it can take up 2 lectures and a whole lab week, it has good application because you can affect facilitation, viscerossomatic reflexes, you can prepare the rest of the body around the surgical site to have the best structure that it can before you. Let's say you're going to do a hip replacement, someone's been walking crooked for 10 years, they've been in pain for the last 5, they finally decide, okay, I know they don't last forever, but I have to have the hip replacement now. Rather than putting a hip into a body that's crooked across the hips and pelvis, you can do some alignment of that ahead of time, then put in your total hip. You're not going to restore the worn joint, but and then post-operatively reducing facilitation, improving lymphatic flow, improving fluid drainage, improving wound healing, avoiding post-operative ileus, avoiding post-operative pneumonia are all potential outcomes of applying osteopathic manipulation in a surgical patient. In terms of the residency program, there are DO residency programs, and I can't guarantee that they're going to be as open or more open to manipulation than an MD program. Sometimes the MDs are like, they didn't learn it, they don't use it, but it's like makes sense when you explain it on an anatomy and physiology level. And so then they're like, sure, let's do that. And then they'll supervise for the procedure of OMM. And sometimes DO programs, I don't know, I think there's some DOs who are a little embarrassed if they don't use manipulation themselves, and so they kind of get a distancing relationship to it. There's some people who come to DO school because they didn't get into MD school, and we try to do our holistic screening so that the people who come are people who want to have osteopathic experience, because that builds the profession and builds patient confidence and the outcomes that we can have. So, but there are a few people who come in and do what they have to do to take a test and then don't use it anymore. So there's a kind of couple reasons of not using it anymore, from I can't fit it into my practice, wasn't that interested in it, or I didn't like it. But in terms of our students, so I don't work with residents frequently right now, more in my training when I was on the East Coast, but our students find that they are, with proper introduction, they're often able to apply manipulation. And then I encourage students out on rotation that even if you're not actually treating someone, getting permission to do the procedure of OMT, that the palpation skills that you gain in osteopathic hands and feel what the tissues are doing and pick up that information and use it in your diagnostic approach. I was planning on demonstrating on a person, but I will demonstrate on you guys so that you can take this home with you. I'm going to give you the condensed version of muscle energy technique and have you assess the symmetry or asymmetry of your cervical rotation or side bending. So if you turn your head to one side and you turn your head to the other side, does it move the same or differently? Same? For those people for whom it was the same, try side bending your head to one direction and side bending to the other. I do not side bend to the left. Now pick the direction in which your neck does not move and let it gently come up against the edge of where it doesn't move. So for me, it's right here. And then take your hand and put it on the opposite side of your head. In the rotation, you might use your chin. And then push your head into your hand for about 3 seconds. 1, 2, 3, and don't let your head move. It's an isometric muscle contraction. Relax 2 seconds and come up to the next edge of where it will move to. And then contract. 1, 2, 3. Relax. 1, 2, and move your head to the next barrier. And contract. 2, 3. Relax. 1, 2. And then stretch through the barrier. Take your head back to the middle. And then retest. Side bending. Got an articulation on that one too. Cool. Any changes? How many people feel neck feels the same as when they started? How many people have a difference in their degree, their range of motion? Okay, how many people aren't sure? Okay, fair enough. So we don't get to muscle energy until about 6 weeks into the curriculum, after we've done some basics and some diagnostics and some ability to feel segments and muscles, and then we apply muscle energy. So, and you had one more question? Or are you good?
No, I was saying that I had.
You went to volunteer. Oh, you have a difference.
Yeah,
No,
I
I
thought you were
meant-
gonna ask for a volunteer. I was like, yeah.
Just quick percentages just off the top of your head. How many DOs go into like family practice? How many go into, OB,
Yeah.
surgery?
So good question. Nationally, the average in I can speak to primary care more specifically than family medicine. So if you consider primary care to be family medicine, internal medicine, family medicine, internal medicine, pediatrics, Some people consider psychiatry, I forget whether OB/GYN falls into that category, but it's about 60% of DO graduates go into those residency programs. Truro consistently makes number 10 on the U.S. News and World Report, primary care producing colleges of all medical schools in the country, with about 58, I think. And then the other specialties have a pretty broad distribution. I think psychiatry was pretty high for Truro this past year. There's a pretty strong cohort of people who do PM&R, preventative medicine and rehabilitation, or physiatry, because of the good correlation with the manipulative skills.
Gotcha. Thank you very much. Thank you.